Hi, everyone. Welcome to the winter conversation. My name is Adina Taylor, and I'm so honored to have been invited to introduce today's session. I've been a Newton resident for the last 7.5 years and welcomed two of my four children to the family at Newton-Wellesley Hospital. My real involvement with the hospital started about a year and a half ago with the opportunity to join the board of advisors. At the time, I didn't know much about what it would entail, just that it would give me a chance to get to know my community hospital a little bit better and work towards becoming more of an advocate in that role. In the end, I was given an even bigger opportunity to get involved and get to know this wonderful team. Last year, this organization helped me reach a personal milestone in running the Boston Marathon, fundraising on behalf of Team NWH. It has also afforded me the opportunity to become more involved and learn more about the ways that Newton-Wellesley Hospital helps our community. Today's topic in particular is a very relevant one for me. While I've been extremely fortunate that I have not yet had to use the pediatric emergency department with four kids between the ages of 3 and 9, it is comforting to know that the support is here and close by. And I'm personally invested in learning more from this discussion around how to prepare myself should I ever need to use this team. So with that, I want to introduce a few very impressive speakers who are going to cover the conversation today. First, Dr. Molly Blazer-Leibowitz serves as the Chief of Pediatric Emergency Medicine at Newton-Wellesley.
I think we may have lost
Pediatric
her.
residency. Did you lose me?
We lost you for a little bit. We're back.
Okay. Sorry about that. She went on to complete her pediatric residency in pediatric emergency medicine fellowship at Boston Children's. On a personal note, she grew up in Newton and has relied on NWH as her own family's hospital of choice. Next, we have Camilla Sutter. Cam has been a child life specialist for 38 years, both in San Francisco and here at Newton-Wellesley. As our hospital's child life coordinator, she guides a team of 7 child life specialists. Together, they provide psychosocial and emotional support for children up to age 21. You'll find them from the pediatric ED to the inpatient pediatrics unit in the pre-surgery area. And their goal is to make visiting our hospital campus an easier experience for younger patients. And then finally, Sarah Kachin-Liu, who may be joining, it looks like she's on, heads the Pediatric Hospital Medicine Division at Newton-Wellesley. After med school at Albert Einstein and a pediatric residency at Johns Hopkins, she joined the NWH staff in 2013 as a pediatric hospitalist. She also provides primary care at Universal Pediatrics, an NWH-affiliated practice in Wellesley. Having immigrated from Ukraine to the U.S. at the age of 10, she's committed to culturally sensitive care for all our patients. And with that, I will turn it over to these wonderful experts for a really useful and informative discussion.
Hi, nice to meet all of you. I am Molly Blazer-Leibowitz, and I'm serving as the Chief of the Pediatric Emergency Medicine. Adina, thank you so much for the lovely introduction, and to the whole team at Newton-Wellesley for having us here to sort of describe our emergency department and our pediatrics department overall, and what I kind of like to think is a jewel in our ability and MGB's system. So here's a picture of Newton-Wellesley, which, as many of you who have visited know, it is a conglomeration of many buildings that seem to be smashed together in the back, where the pediatric emergency room is in the back of the hospital, located within the regular emergency department. Go to the next slide. And I just wanted to start out with a few facts about our pediatric emergency department. So we see kids from age birth up until they turn 23. So most people are saying that's not necessarily a child anymore, but we are happy to take care of patients until they are basically graduating college. We have an expert team that is staffed by pediatric emergency medicine physicians and pediatric trained APPs. Our pediatric emergency team is available between 8 a.m. to 5 a.m. We are open, obviously, 24/7, and the rest of the emergency medicine team is very skilled in taking care of pediatric patients. We see a high volume of patients. In 2024, we cared for over 22,000 young patients, making us the busiest pediatric emergency medicine department in the MGB system and second or third in the state. Next slide. I'm going to send it over to Cam right now.
Hello, everybody. So one of the questions we often get asked is, what is the process? How does it work? And why do we have to wait so long? So if you all were children, this is how we would explain the first initial entry to our emergency care system. I want you to imagine that you are on a pirate schooner and you have to get to the pot of gold. This is actually an image we do use to kids to help explain the process. So the start is the parking lot. You can park in the parking lot or do valet, both are fine. And then there's a series of trips that your boat needs to take to get to different locations, with the ultimate goal being the pot of gold, which is getting in and being seen by the emergency care team. Now, if you're a child, you're going to need to, this is helpful because you're going to need to stop at the bay of registration, and you need to go to triage island, and you need to do all these steps. And each step, each island and each stop has concrete tasks and things that can be done very quickly and efficiently. The problem is, and this is a problem for all healthcare in America, the journey between the stops is a little unknown. You don't know if you're going to have turbulence or waves or a weather front. And so, although each stop is mandatory to get to the island, to get to the pot of gold, your journey along the way is unknown. And at times, if you come in, we can zip you through these islands, and it's a quick journey. And there's times when it's very sloggy and very slow, and you have to be patient and wait for the next island to approach. So this image is helpful for kids. We hope it's helpful for you. This is just simply to get in to be seen. So you can see there are many steps. Next slide. These are the steps in more adult language. So upon arrival, you are met at the greet desk. The greet desk is your initial contact. If you're coming to visit a family member, you would get ushered in quite quickly. If you're coming in for care, they would help direct you to the right stations. We hand out masks, hand wash, all those sorts of things right there. Then you need to go to registrate. Then there's a wait. Then you get called up to registration, which is where you submit identification, insurance form if you have it, insurance information. We give your child a name bracelet. That's the start of letting us know right there that your child is in the system. Then you go back and you wait. Then you go to the triage desk, and that's where you are assessed by a nurse to decide how ill your child is and how quickly we need to get you back. The blue dot, which lost its sign on the bottom, says emergency room entrance. And that's when you actually, when all these steps have been done, then your child is brought back to our area to be seen by our health team. Next slide. And I'm passing off to Sarah or to Molly to explain the process of how we decide how quickly people can get seen.
So we thought it would be helpful in this discussion to tell you a bit about sort of the journey through and to the emergency department through the eyes of a specific patient. So we're picturing sort of a 5-year-old girl who's here with a parent and a grandparent. And again, this could be applied to honestly anyone 0 to 22, but for our purposes, we can give a little bit more information, and that she is coming in with some fever and some vomiting. So when we look at triage levels, and I know compared to every other line that you wait for, you know, when you check into something, it's usually you check in and you wait your turn. This is one of the few places where that is not exactly what happens. Yes, you check in and you wait your turn, but it is not based on who comes first. And this is sort of what our triage levels talk about. It is an acuity thing to make sure that the highest acuity, otherwise known as the sickest patients, are seen first, and that people who can wait or have non-life-threatening conditions might have to wait longer. And it might seem unfair when you're sitting and waiting and thinking to yourself, my child is so sick, I've been waiting forever. But we like to sort of give you a range of sort of the triage levels. So this is a universal triage systems used by nursing across the country. And it's levels 1 through 5, 1 being the worst and 5 being the least complicated. The most common, honestly, are levels 2 through 4. We rarely see 1s and 5s, but they do come in. So I'm going to sort of start at level 5 and go backwards. So level 5 is a patient with non-life-threatening symptoms, is in stable condition. we think of that as, something like an ingrown toenail or somebody who comes in who needs a medication refill. They're there and they will be seen, but it might not be as quickly as you would want. Level 4 is the patient is stable but has injuries or a condition that needs medical attention. This is one I'm going to put in as a kid who bumped their head and has a big cut across their forehead that likely needs stitches. And I use this one because I think it's very surprising to parents and families that when a kid who obviously needs stitches would be made a level 4, which seems like, they're bleeding, they need to be seen. And we absolutely agree they do need to be seen and they do need medical care, but are not as acute as other medical conditions. And while it's very frustrating, it's sort of how we balance out the needs of the department. Level 3 is what we would say our patient who checked in, this 5-year-old girl with vomiting, would be. Patient is stable, but is going to require multiple types of resources to be monitored and treated. So for us, that would be a child who needs some medication, maybe an IV, maybe imaging, but their vital signs are stable. Compared to level 2, which is a patient who shows signs of distress or experience a condition that can become life-threatening and will need to be reevaluated. These patients need more monitoring and more interventions. So this is a patient who could also have vomiting and a fever, but because of their illness, their vital signs are not stable and they would need more interventions and more care. And then level 1, thankfully, is more obviously rare. In a pediatric patient, this would be a patient who comes in not breathing or whose heart has stopped. So that just gives you sort of a range of all the different sort of patients we see. And then we can go on to the next slide. And comes to our waiting area. So this is not our emergency department, and clearly ours tends to be filled with patients. And overall, our goal is to bring patients back as quickly as possible, both for the family's sake, the patient's sake, but also in terms of getting care started and treated. We'd love to have patients brought back as soon as we have space. We also like to tell people that while you're in the waiting room, you are not seeing the whole picture of who is coming into the emergency department, because it doesn't include all the patients who are coming in by ambulance, who might be brought in by the back. And these tend to be, unfortunately, the more acute patients who needed an ambulance. So our beds tend to be filling up in places that you can't even see. I'm going to go to the next slide. So this is our emergency department. I'd like to show a visual of it. So we have 8 pediatric rooms and there's 2 entrances. Just for safety's sake, our pediatric department is an entirely locked unit. To get in from the waiting room into the emergency department area, you have to be badge swiped in, and then there is another badge swipe in to pediatrics, which means we are sort of insulated within the department. We have 8 beds. And then if you can go to the next slide, we have many extra hallway beds. And I know there's been a lot of discussion sort of in the news and in healthcare in general about the volume of patients that are coming in and sort of what we're able to do to accommodate for these patients. So unfortunately, we do need to use hallway space, which lends itself to some less privacy and different kinds of care. But it is also our way of almost doubling the amount of patients we can see in our department at one time. So for our rooms, we have 8, and we have the equivalent of 7 to 8 hallway spaces within our department, which means that we can move patients through and see them more quickly. Next slide. Going to hand this over, I think, back to Cam. Oh, no, sorry, I'm me. This is, sorry, I apologize, the sort of picture of hallway medicine. This is, again, not our emergency department, but it is very similar to what you might see, is a bed in the hallway without the full monitoring that we're used to, and definitely less privacy. So it's a different way of seeing patients, and we choose who is going in the hallway. And honestly, for the most part, we're putting patients who are less infectious, so not having fevers, not having vomiting, and not needing breathing treatments. Those patients need rooms. And obviously our more acute patients who need all the monitors we have in rooms go in rooms. other patients, such as people with cuts, orthopedic, bony injuries, and belly pain are some of the more common patients that we're seeing in the hallways. We do our best to try to create a sense of privacy, talking quietly or bringing family members into different areas so we can give patients the respect and privacy they need in the hallway. Next slide.
Well, I will do this one. Hi, everyone. I'm Sarah. I'm the pediatric hospitalist. And what that means is I'm a pediatrician who sees patients once they get admitted to the hospital, which we'll talk about a little bit later. But I wanted to introduce you to the medical team. So while you're in the emergency room, you're likely to meet many, many people. And those people comprise our medical team. So of course, you're going to meet your doctor or the physician. You may meet a physician assistant or a nurse practitioner who also takes care of patients and evaluates patients, makes diagnoses in the emergency room. We work with resident teams. Residents are doctors in training. And sometimes we work with student teams as well, who may be medical students or physician assistant students. Our residents are full-fledged doctors. They have their doctor degrees. But they do work under supervision for the first few years to make sure that, again, that we're taking really good care of patients, making the right diagnoses, and giving the right treatments. You may encounter consulting physicians. So if a child has a problem that requires specialist consultation, for example, someone with a chronic gastroenterological complaints, you may need to consult a specialist like a gastroenterologist, and that person may speak with the patient in person, they may speak with the patient by phone, or they may speak with the emergency room doctor, depending on the situation. And then ultimately, if the child needs admission, you may meet the pediatric hospitalist, who is the pediatrician that will care for your child past the emergency room. Next slide, please. There are also many additional care members that work as a team to take care of each child and to make sure that each child has the best possible experience. There's the nurse. So at every stage, your child will have an assigned nurse that cares for them. There's a technician who might place an IV or take blood work or do studies like an ultrasound, an EKG, or casting and splinting. There are very important child life specialists like CAM, registration staff who will check you in. There are respiratory therapists who provide breathing treatments and help us assess patients with lung concerns. There's transport that moves patients between the different rooms and areas of the hospital. And there's, of course, radiology that does all of the studies and imaging that we may need to do. Next slide, please. So I will go ahead and hand this over back to Molly.
Wonderful. So once your child makes it into the emergency department after hopefully not too long waiting, you'll get settled into a bed. So that could be either in the room or in a hallway. And sort of what is going to happen next? You're going to have an initial assessment by your pediatric team. So that could be first a student. It could be an APP, which is a nurse practitioner or a PA, or it could be the doctor. I know it feels that you might tell the same story many, many times, and we are aware that it seems to be repeating yourself, but each person who's asking these questions is looking for slightly different information. So when you tell your triage nurse what's happening, they're trying to put you into those broad categories about who needs to come back first. And then you'll meet your initial assessment team, which would be your nurse in the pediatric department, and then your medical team. And they're looking for slightly different information. What brought you in? What do we need to do to figure out what's going on and how we need to help you? So that includes a thorough history and physical exam. And then from that, sort of a discussion and thought from the team of what we're going to do. So that it can do tests and procedure and consultations. So some of the tests and procedures that might happen to your child is blood work for laboratory testing. That can be urine samples. That can be medication. That could be imaging studies. We have availability of the broad spectrum of imaging, X-rays, CT, MRI, and echo, which is ultrasound of the heart. We have general ultrasound too. A general question that parents often ask us is, are these people trained in pediatrics? And what we say is that each of these techs works from birth through, 100 plus, so they're well aware of pediatric concerns and issues. And in terms of imaging that has radiation, we do dose reduce for pediatrics in compliance with all the latest data and regulations. And our radiologists are not on site, but are being read at the Brigham and MGH and include a specialty group of emergency medicine and pediatrics. So we're sort of all the behind the scenes people. Some other tests and procedures that you might have are an EKG, which are stickers to monitor heart rhythms, just general monitoring, which I know people don't think of as sort of an intervention, but stickers on your chest, little probe on your finger looking at your oxygen level, which is all reported back to the doctor's station so we can see it in real time. And sometimes your child, when they get blood work, we put an IV in to give in intravenous fluids, and sometimes those medications need to be IV too. So when we think sort of other things that could happen are consult teams, and we work with a broad range of consults across the MGB system. I like to sort of divide them into the surgical specialties and the medical specialties. And we have basically every site covered. We have a pediatric surgery and pediatric orthopedics and general orthopedics, and that's done through MGH surgery and the orthopedics groups at Newton-Wellesley. We have ear, nose, and throat, and we have urology. In terms of the medical specialties, most of these people are located at MGH and have clinics at Newton-Wellesley, and we speak to them by phone. So you as a patient and a parent might not meet these specialists, but the discussions might be ongoing in the background. So after some of your tests and procedures, I might get the information and call a GI doctor and say, this is what's going on. These are some of my results. What do you think the next step should be? And we sort of pass that along. So if we're thinking about our patient who checked into the emergency room with vomiting, they made it through triage. They were triage level 3, and they got back into a bed in a room. And the nurse would come in and say, check out their vital signs again, put them on a monitor, and then you might have a PA or a doctor come in right away. And I would do a history, physical, and look at them. And maybe what I would see is a girl who's been vomiting overnight a lot and has some belly pain. And with that, I think to myself, do we need IV? Do we not? And what are we sort of do there? Is this the stomach bug that's going around? Is it not? Is this something I worry more about, like an appendicitis? And for that kind of child, I probably would give nausea medicine, and depending on how dehydrated, put an IV in, and then maybe get an ultrasound to sort of figure out, do I think this is appendicitis or not? I know in the news it's been going on recently that there's been an IV fluid shortage. So we've had, with some of the storms in the south and in the middle of the country, actually destroyed the locations that made all our IV fluids, and we're having a severe shortage. So the patients that often used to come in and we would give IV fluids to, we've been trying to do oral rehydration, which is actually extremely successful. And I think we've learned a lot about how much we can actually do this in the pediatric population. Giving nausea medicine, and of course, if that's not working, we can do IV fluids. And coming up right now is that the IV fluid shortage seems to be a little bit improved, but we're actually running into specialty IV fluid situations, which is how do we provide dehydrated children with the amount of sugar they need? So you'll see people thinking to themselves and maybe being creative in these shortages of how we provide our care. Similar thing happened last year with antibiotic shortages. I don't know if any of you had that. You went to your pediatrician, you wanted amoxicillin for your ear infection, which is our go-to, and then realized that amoxicillin was out. So this is sort of part of that whole workup and consultation. Next slide. This is a sign from the actual emergency department. We were joking as we put it together that we're not sure why the background looks like flames, but this is actually what's in every emergency department room. And it is sort of to let you know how long each of these things take. Because the emergency department is a very frustrating place where it feels like a lot of hurry up and wait, hurry up and wait. And you have these little goals along the map. So as Cam showed with that pirate map, we're trying, our first goal is to get into the emergency department. And once you're there, what are we doing in the meantime? So this is a sample of how long all things take to come back once they've been done. So this is, you might need to wait to get your blood tests. You might need to wait to get your imaging tests and your calls. And once they've been completed, this is the time frame we're talking about waiting. So I would say on average for a pediatric patient, it probably takes a good half an hour, once you're in an emergency room bed to get your blood tests and imaging. And that's because it's actually more difficult in kids. We want to make sure we're doing the right support for them and providing the comfort and care they need. And we need the right nursing care to make sure we're holding them properly and to get an IV in. Once that's in, you're going to be waiting from an hour and a half to 2 hours for blood tests, up to an hour for urine. And in imaging, I know it's sort of a lot to picture, but up to 3 hours to get results of scans. And this is because we're reading images from all across the system, and they also prioritize by acuity. So how sick the patient is, what gets read first over the whole system. So if there's a car crash that goes to MGH, that's going to be read before a CT scan for appendicitis. Next slide. I'm going to pass it back to Cam right now to talk about our amazing child life team.
So intermingled in all of this care, you and your child will be meeting a child life specialist. And I'm honored to work with a remarkable team of women who provide this support. And our job is to enhance and allow for coping with a hard day. So whether you come in through the emergency room, pre-op, inpatient, wherever you come in, we'll try to be available. And our job is to make it less scary and help you and your child cope with whatever is scary for you for that day. So going back to the patient that was admitted, our hypothetical patient, let's say she needed some blood work sent to the lab and an IV. Our job as Child Life is to meet you right away, often bringing toys and art supplies in our hands just to show that we're friends, and sit with you and your child and figure out how we're going to get through it. Some children are information seekers and want to know a lot of information. And for those kids, we might do a sample blood test on a doll. Some kids are information avoiders and really prefer to just a lot of distraction, a favorite video, a Bluey book, whatever it's going to be. So we sort of will cater the way we approach that based on your child and what you tell us about your child. Let's say that our patient, this young 5-year-old with nausea, needs to go to ultrasound. It is very likely that we would help explain, probably using a doll, what's going to happen in the small ultrasound room, right? Luckily, it's not a test with needles. Everyone's worried about needles, so we explain that quickly. We will have like a little sort of a fake probe, and we can show them talk about the jelly on their belly and try to make it a little lighthearted, but with honesty and with truth, and letting, of course, parents be present whenever possible. So parents can be present at almost every procedure except for CAT scans, where you have to step out for just a moment. But every other time we try, as a hospital, to have you present with your child. You know them the best. You are the most support to them. We would like you in the room, at their feet, helping hold, helping comfort. That's an important part. Back to our young patient. Let's say she has just a long wait while she's waiting for that blood work to come back. We're the people who have the toys and the art supplies and the games and all that stuff. So by all means, you're welcome to bring those things, but please keep in mind that in all of our settings, we have things to keep your child busy and occupied. We'll be going over some lists of ideas for things of you to bring, but please keep in mind, Child Life, we are available for the very basic sort of recreation and diversion needs as well. If your child has special needs, we can accommodate certainly as well. We are known in the system as being very accommodating to patients on the autism spectrum. We can turn the lights down. We can have weighted blankets. We can minimize stimulation. We can do whatever you need. And we truly depend on you as parents, if you have a special needs child, of informing us as a team and letting us know what you need for this visit to be successful for you and your family. So these pictures just show a few of our things we do. Some of it's basic play. That's me getting a kid ready for surgery. We can offer distraction during a procedure. So if the child needs a cast, ortho can do their business and we can keep you and your child engaged. We can either select the book and you read the book, or if you're feeling like you need a break, we can read the book and you can just hold your child, whatever. We're very flexible. Try to make it as pleasant as possible for your child. Distraction, we're very good at distraction. We have all sorts of fidgets and gizmos and bubbles and blowers and of course technology. And then if someone's going for something specific, so for instance, a CAT scan or an MRI, we do have models of these devices to show and to practice with small dolls or Barbie dolls and help sort of rehearse it so then when they go downstairs, it's all not new and unfamiliar. You as parents and family are a vital part of doing all of this. If you communicate to us what your child's worried about, what their biggest stressor is, what their experience was before, we can try to make it better. We work closely with the doctors and the nurses and really everybody in that whole team, on that team sheet. We all work together. Our goal is to get you quick care, efficient care, non-traumatizing care, get your kid feeling more comfortable, healed up, fixed up, sewed up, whatever needs to happen. You are a huge part of that. And the family-centered care approach is very strong in Newton-Wellesley. We invite you to, talk to us, explain to us, be involved with us, help us take care of your child. So that's child life in a nutshell. Next slide.
So it may be, in the case of our 5-year-old, that in fact she doesn't have appendicitis, and she received medications in the emergency room to help with the nausea, but she hasn't been able to eat or drink. And so because of that, the doctors in the emergency room would like to have her stay overnight at the hospital so that we can do IV fluids and make sure that she feels better the next day. And so that's where I come in. If inpatient stay is needed, likely at that point, a patient with belly pain and vomiting has been in the emergency room for evaluation for about 5 hours at the time that the admission decision is made. And so if that patient needs admission, the inpatient medical team, the inpatient pediatric doctors get called and come down to see the patient, usually in the emergency room, sometimes on the pediatric floor. So you'll need to get more medical professionals. The doctor's going to come down, ask you some of very similar questions that you. Oh my gosh, I'm so sorry. There's naturally construction next door that you've heard already. And the reason that we ask some of those medical questions is just so we have a good understanding that we know all the medications and allergies, that we're not missing any parts of your prior medical history. So please bear with us as we ask some of the questions you've heard already. You'll meet your child's medical team. That may be a pediatric hospitalist, that may be a resident team, as we do have pediatric residents on the inpatient floor. And then from the time that the decision is made to admit to the time you land in this lovely pediatric room, it's usually about 2 hours. And you would come up to the inpatient pediatric unit, which this is a picture of one of our rooms. So all our rooms are private. We have 12 pediatric rooms on our pediatric floor. And we prioritize all children from birth to 18 to be on the pediatric floor. Older young adults may at times be admitted to the adult beds. But this is one of our pediatric rooms. There's a bed for the patient, there's a table, and you can see a bit of the couch on the side there that unfolds for a care provider to stay and sleep there. And parents are always welcome to stay with their kids. There's no visiting hours for parents. They can stay day and night, and we do encourage it certainly for kids to have the support that they need. We have a primary medical team. We have certain specialists that are at Newton-Wellesley and may come to see you in person. We also work with specialists at Mass General Hospital, so sometimes you may have virtual consultations with those specialists. We really do try to keep all our patients local and convenient to their homes and provide very high quality care in Newton-Wellesley. We also have a lovely playroom where Pam and Child Life colleagues help us entertain the kids and make their stay less boring and less kind of isolating. We do have our patients without infections come and play in the playroom. And for patients who can't leave their rooms because of infections, these toys will come to them and activities will come to them so that they have a great stay as well. Sometimes, rarely, but sometimes we do need to transfer our sicker patients down to a tertiary care center, either for specialist consultation or higher level care like an ICU. And if that happens, then we work seamlessly, usually with MGH, to get that transport done. But most of our patients we can care for right in the community. Next slide.
So I wanted to take a minute to talk about behavioral health care. Before I do so, I wanted to sort of tag on to the end of what Sarah said, and that our goal is, if patients need to be admitted, is to keep them with our excellent hospitalist service. In the case that some patients come to our emergency department and need to go to one of the tertiary care centers, so mostly MGH, but also to Children's or BMC, that can be arranged directly from the emergency department. And we arrange ambulance and transfers sort of all behind the scene and get you to where you need to go. So I know that behavioral health care is certainly a large portion of what we see in the emergency department and reasons patients come in. I wanted to do a brief sort of interlude about that. So we have 24/7 support. We have emergency department specialist social workers that are there 24 hours a day to provide counseling, evaluation, and resources to children and families facing challenging situations. We do have pediatric psychiatrists available. They are not in the hospital 24/7, but they are available by phone if necessary. And if there's a consult needed, often the child can stay overnight in the emergency department awaiting pediatric psychiatric evaluation. Some of our patients need sort of an evaluation and a discussion with our social work team, and then hopefully they will be able to go home with their families in a plan. Sometimes people need to stay for mental health admissions, and it is our ED social workers' job to organize that and work closely with the entire MGB team to coordinate patient placement within the system. We work with the MGB Patient Placement Center, which has actually decreased the amount of time most pediatric patients need to stay in an emergency department awaiting beds. And so I would say it's been a huge help for families and patients trying to be in the emergency department and getting to where they need to be. Next slide.
So we wanted to review with you some lists of things that you might want to bring should you need to bring your child to us. It's some stuff you can just sort of throw in your bag, but if your child's sick and you think it's coming, you might want to sort of take a moment. This is the parent list, and we're happy to share this with anybody who wants in PDF form. These are things that are really handy to have in your bag. In the same way you might have a labor bag if you're pregnant. It's really nice to have sort of a hospital or doctor visit bag. These are some things we recommend in them. Basic essentials, your cell phone and a long charger. So our chart, just so you all know, because this is we get asked this every single hour. The chargers are on the wall, and if you have a long cable, you can plug in. Otherwise, you have to have your phone sort of attached to the wall far away from you, and phones are vital for connecting with the rest of your family and your other children. So put a long charger cable in your car or something so you have it. That's our #1 request. Maintenance medicine, if your child takes medicine every night before bed, if they're on an asthma inhaler regularly, bring all that stuff. It's certainly helpful. We can certainly get those medications, but if it's something you know and they need it soon, just toss it in your bag. Hand sanitizer, we have a lot. Paper pad to write down your questions. Do you have ample time during the waiting processes to think about things you want to ask, questions you have for various members of your team? Sometimes it's helpful to either have a notepad on your phone or an actual notepad just to jot those down. Care of your kid, we will have all of these supplies, but if you know you're going to be in the waiting room for a little while, it's nice to have your own right-sized diaper or the wipes that your child's bum likes. So in a pinch, we can provide any of these things for you, but sometimes getting the exact correct size diaper can be a challenge. It's nice to have the basics that you need, particularly for the waiting area out in your pirate treasure map section. Next slide. There also are some items that we recommend bringing for your children. Comfort items are huge. If anything, forget the insurance card and get the blankie, okay? The blankie, the lovey, the binky, please bring that. It is very comforting for kids to have something from home that reminds them of home, that smells of home. Nothing alive, please. And just toss it in the bag. We've had, it can be a pillow, nothing gigantic, we don't need whole bedding sets, but a pillow's fine. Blankies or treasured blankies, stuffed animals are welcome. Food or drink, unless your child has a GI problem, is fine if they're waiting and they need a little pack of goldfish or something. There are some vending machines nearby, but if your kid is finicky or only likes a certain type of cracker, then bring the cracker. Snacks for yourself. Like I said, if you're out in the waiting room and it's one of those long journey pirate trips, then throw in a granola bar, throw in a water bottle, have some stuff for you. We will have snacks once you're inside and cleared and your child is cleared to eat, but it's simple stuff, popsicles, saltines, pretzels, Cheerios, stuff like that. So nothing fancy. And if your kid is finicky or has food allergies, please bring those along. Entertainment, primarily for the first waiting area. Once you're inside, we can probably give you things for your child to do, keep them busy, keep their hands busy, keep their minds busy. But for the waiting part, anything is welcome. Favorite books, tablets, whatever you need to bring just for that waiting period. It does help time pass and help keep them distracted from other sick people around them while they're waiting. Essentials, if your child really likes the purple sippy cup, please bring the purple sippy cup. We have sippy cups, but it may not be purple. I don't want to upset your kid. Extra diapers, specialty formula. We can probably get most of those from upstairs, but like I said, in a pinch, it's always nice to have your familiar things from home. So this is sort of the kid section. If your child is well enough, let them pick one or two items themselves to throw in the bag. If it's a rush item, then just grab what you can and come on in, because we will probably be able to provide it for you once you're in and give you whatever you need in any of these categories. Okay, next slide. So we have journeyed with you from beginning to hopefully a quick retreat from our emergency room. We would love to be open for questions you all have from about the experience, any tips, advice, questions you have for us. We are open and we appreciate your time with us.
Awesome. Waiting for my colleagues to mute. Awesome. Thank you so much, Molly, Cam, and Sarah. It is just fabulous and fortunate to have all of you here at Newton-Wellesley. We're so grateful. And I learned a ton, including no snakes in the ED. What a bummer. My name is Katie Connolly. I'm the Chief Development Officer here at the hospital, and it's a real pleasure to welcome all of you here today with us virtually. I'm going to play facilitator for this. We have about 10 minutes for Q&A. In order to facilitate, I'm actually going to jump back off, but I'm going to invite up to join the panel our Chief Nursing Officer, Sandy Muse. So I will be a voice, but not a face, and Sandy will be a face and a voice. And we look forward to hearing from all of you. Please use the Q&A little button at the bottom of your screen to post your questions, and I'll try to get through as many as I possibly can. We also got some in advance, so we'll just do our best to work through them. Sandy, join us.
I think I did, but I don't think you can see me.
Oh, I may be coming back. We may have lost our Sandy, so then you can look at my face after all. Excuse me. Okay, I'm going to jump in with an awesome first question, and it was clarifying. It's from Amanda. Cam, you mentioned on your list of things to bring things like vaccination records. And Amanda asked this great question, which is, if your child's pediatrician is part of the Mass General Brigham system, are you able to see those records in the full medical record in RED?
Cam,
Molly,
maybe
do you
I'll,
want to answer this?
yeah,
Go ahead,
I was
Molly.
going to say that's an excellent question. So if your pediatrician is part of the entire system, we should be able to see your vaccination records and your pediatrician's notes and prior hospitalizations. So that is absolutely possible and should be available. The
Really
caveat
good question,
to
Amanda.
that
And I
is,
think from Cam's perspective, it probably was advice to be as, in case you happen to be visiting an emergency department that is not part of the Mass General Brigham
Yeah.
system. But really good question, and thank you, because a lot of people don't actually know that your pediatrician's database would talk to the wider system. So really good question.
can I just add?
Again, please pop your questions in. We got a couple in advance. I'm going to jump right in with one. This is, I think, maybe Molly, this is a question for you, Dr. Lebowitz. Our kids have lots of different types of emergencies. And actually now the environment around us can respond, and there are facilities that can respond to different types of emergencies. So we have our emergency department, we have urgent care that Mass General Brigham operates and others operate. And then we and others also operate things like our ortho walk-in clinic. How would you help a parent sort of make those decisions in advance of coming to the ED?
I think that's a really great question because we do have a lot of specialty care locations and a lot of options. One of the things I suggest is, if you have time and you don't need to call an ambulance or something like that, you can always put in a call to your pediatrician's office, because they can help triage what is available and where the right place to go is. You can call the emergency department, and we are happy to answer questions and sort of direct care. The side to that is, I am often the one, when I'm working, picking up the phone, which means that if you're busy, you might not get somebody to answer the phone and answer your question, but you are always welcome to try. The pediatric orthopedics care is excellent at the walk-in clinic. They take care of all children, so I highly recommend them. The different different urgent cares have varying levels of comfort with children. So I think you just need to know your local urgent care and know how much they would need. For most kids who need breathing treatments, who might need an IV, who might need imaging, stitches, a lot of urgent cares will not do that for pediatrics, and you're going to end up in an emergency department.
Thank you so much. I'm not even sure who might be best able to answer this one, from Carol Ann. She's curious about the BRAT diet, and I'll ask someone to explain that acronym as well. For a child or grandchild, she notes, who might have a GI problem. Has that been updated? In what ways? What are your thoughts on that sort of home care response?
Sure, I can take that one. So bread diet, which stands for bread, rice, and
Applesauce.
applesauce, and is it tea? Toast.
Toast.
Toast. Bread, rice, applesauce, toast. Is basically an acronym to suggest a very bland diet that has been recommended for things like gastroenteritis or abdominal upset. I would say in general, I'm not sure that we frequently recommend that particular diet anymore, but we do generally suggest a bland diet after any sort of GI upset. And importantly, we suggest that kids avoid milk and dairy for a period of time after any sort of GI illness, because the enzymes that help digest milk and dairy tend to take a little while to recover after any kind of stomach bug. So that basically is still the recommendation: bland diet without dairy. And I'll generally say, if a child wants to eat something, they really want that thing, that's fine. We really care for them to drink, and mostly drink, but eat something. Whatever they prefer is fine. Keeping in mind that dairy may not be the best choice in that moment.
Thank you so much. Cam, I think this question might be for you. It came in and I know it was a big part of what we what I often talk with Sandy about, our chief nursing officer. How do you and your team partner in the ED with our spectacular colleagues in the nursing department?
We are very close to the nurses. So the ED is, as you saw from the map, is kind of a small, cozy unit. And because of that, all of us are talking to each other all the time. Somebody will leave the room and sort of swing by our desk, which is in sort of the black section of the map, and be like, hey, looking like a line in labs in room 6. And what we'll do is, we sort of get a heads up. We'll go gather some supplies. Hopefully we've met you already in room 6, and then come back in and be like, so what did you hear from the doctor? And then we sort of explore with the child what they heard, because sometimes what kids hear is different than what the doctor said. So we make sure that everyone understands, and then we come up with a coping plan of how we're going to get through that thing. Sometimes the things aren't scary for kids and we can just kind of pop right through it. Sometimes it's really fear-inducing, or they had a bad experience before, in which case we have to slow down, pump the brakes. And what we find is that nursing and the medical team we're all sort of reading each other and balancing things out. So if your child needs a longer time to be explained what's going to happen, or to practice breathing and practice holding their arms still, the nursing will actually hold off on the test unless it's an emergency and unless it's, a life. It's important for breathing and that sort of thing. If they have time, we will all balance each other out, sort of seesaw style, as far as nursing will hold off and wait until we have a clear plan with the family and the child on how they're going to cope with that thing. So it's very much sort of constant communication. Our nursing colleagues are spectacular and we love working with them. And by, talking to the PAs, talking to the NP, talking to the docs, we're all sort of constantly sort of talking to each other in the middle of the room, coming up with plans and timing to make sure that the child is as ready as they're willing to be. Not all the things are fun, but and that we have a plan on how we're going to all get through it, including the parent. Is the parent, do you want to be involved? Do you want to be at the head of your child? Do you want to hold their hand? Do you want to leave the room? All of those are fine options. And again, the communicating is key in the whole unit. If you tell us what role you want to play, if it's reasonable, we will accommodate it. And if you need, sometimes people just need to say, I'm going to sit down in a chair, I'm exhausted. Can you guys just get it done? We can do that also. So constant communication, that's the joy of our job. And sort of the fun part is sort of working with each other to do good care for kids.
Love that. Communication is sort of the backbone of our whole hospital. I think we have a number of additional questions. I'm going to do one more, and I promise to all of you who asked us questions, if we didn't get to them, I promise we will get back to you directly to make sure you have answers. And if other things pop up for you, you can always be in touch with our office, and we can be in touch with all these fabulous clinicians to get you information. But this last one was I had never thought of this, and I'm very curious, and you may all have comments on it. Hopefully this is a rare occasion, but if we have a child who's hospitalized with us for a long time, are there ways that we can keep up with their schooling? Is there anything we do to support that? And also, if they happen to be, in earlier stages of development, are there things that we have in place up on the floor to support important developmental milestones? I see a lot of head nodding. I think you maybe all would have comments on that, but maybe we'll start with Dr. Cock-and-Liu.
Sure. So I think it's quite rare for a child to be hospitalized long enough at Newton-Wellesley for these to become concerns. And I know Campbell will have a lot to say about developmental milestones. When we do have a child stay longer, first of all, for any hospitalization longer than 3 to 4 days, we work with our social work colleagues to connect with the family, because often once you get into that duration, there's logistical issues that come up. If there's other children, who's caring for them? If there's work, how is that being managed? So we have our social work colleagues step in and provide any resources that are needed for those longer duration stays. We have had families then connect with the school and share their predicament, and the school will send work or will allow students to participate in a virtual way. Sometimes teachers have come to visit, or friends from school have come to visit as well, and brought packets for children to work on while they're in the hospital. And then Cam and her colleagues help us set up a schedule and a time to make that possible. Certainly, as far as developmental milestones, for kids where we are able to get them out of the room, especially younger kids, we try to have them walk, we try to have them come to the playroom and interact with items to help support that. Again, I would say it's quite rare to have someone stay long enough where that becomes a significant concern, but we do have resources when that does happen. I'll hand it over to Cam for some more specifics.
I think you're spot on, Sarah. So we do communicate with schools. If families feeling overwhelmed, we can call your child's school and find out. It is often a short admission, in which case it might just be explaining to the school that the child's in the hospital, and you usually get a sort of a pass for a few days. We can arrange for homework to be scanned and sent to teachers, sent back. We can do homework time if your child's feeling well enough and just sort of is stuck in bed, then we can certainly, every day from 2 to 4, it's homework time. The developmental concerns is a big focus on our department. We want kids to be exposed and stimulated in the ways they need to grow and thrive. And if your child is feeling poorly, we'll back off a little bit, but things, really a multi-sensory approach. Is there music in the room? Is there rest time? Is there quiet time? Is there time to see natural light? Is there time to go and play? All those things are tied into our goals as a child life team, and certainly are taken into account if you're in the hospital for more than a day or two.
Dr. Lebowitz, anything you want to add?
No, I would say that both Sarah and Cam have done an excellent job in describing what we do, and hopefully that most of the people I see do not need to get admitted in general.
Fabulous. Well, we have 1 minute to spare, which is always a pride point for us. If we manage to celebrate all the incredible things that happen at Newton-Wellesley, but do it on time. I feel so grateful to Dr. Lebowitz, to Dr. Cock-and-Lew, to Cam, to Adina for opening up our program and being of such important service for us on our board of advisors. To Sandy Muse, who I know is with us. I think we just had a little technical difficulty, our chief nursing officer. There is just this breadth of talent and passion in service of Newton-Wellesley, which means in service of all of you and your families, and today, most importantly, your children. We're grateful that you let us be part of how your family receives care, and we are here for you. With that, I wish you all it's hardly winter today. I wish you a beautiful rest of your day, and we look forward to seeing you at a future event.